I'm going to talk about deep brain stimulation for movement disorders, elective brain surgery for quality of life. Kind of emphasize. Thank you. I emphasize that because these things, Parkinson's and tremor, they're insidious, right? They kind of creep up, and people kind of adjust to being part of their life. And there sort of comes a point in the disease where they look at themselves in the mirror and they say, all right, am I really going to sign up to have this surgical implant? So implantable neurostimulation, which is used, is actually on label for improving quality of life. It's a big deal, and the stakes are pretty high, and I think similar to what we saw in epilepsy, there's not much room for complication with these patients, and I think that is reflected in the slow rate in which temporal lobectomy has been adopted despite level 1 evidence from the New England Journal trial. Do some consulting for Medtronic, and I'm going to talk about deep brain stimulation without test stimulation. So the FDA labeling stipulates successful test stimulation in surgery to leave a lead. So I'm going to talk about DBS in 2017, what's new. I'm going to talk about some functional anatomy. A lot of what we see in courses is like skull-base anatomy and cortical anatomy. But one of the great things of Dr. Ribas's work is we really get a sense of the intraparenchymal anatomy. And that's what functional neurosurgery is all about. So I'm going to review some of that and then discuss some of the surgical methods. It can be thought of as DBS being the highest impact therapy for Parkinson's since levodopa was introduced in the late 1960s. This is kind of, we're still in the surgical era. And the reason why we do deep brain stimulation for Parkinson's is shown in this slide. This is a diary from a patient, 7 a.m., 8 a.m., midnight, breakfast, lunch, and dinner. The patient takes medications 4 times a day. And what this shows, the on at the top and the off down below. Off is when the patient's having the cardinal features of Parkinson's, tremor, rigidity, bradykinesia. So what the natural history is with patients who are taking medication for Parkinson's is that they start, the absorption, the transport of this medication changes over time, and they start getting fluctuations. So they're up and down. They can't predict when their symptoms are going to be controlled. So what DBS does, that becomes a major driver of disability. And DBS basically captures the best response patients have to levodopa therapy and maintains it. It gives them more time in that so-called on state. It helps reduce dyskinesias as well. Those are abnormal involuntary movements that are side effects of medication. This is the JAMA study that came out from the VA, and what this highlights is a randomized trial between best medical therapy and surgery where DBS was superior, and that was kind of hands down. Patients were getting about 5 hours of that on time without dyskinesias compared to patients who were randomized to medicine, and quality of life was improved. It's underutilized. Only about 150,000 people have undergone DBS worldwide in the 30 years that it's been practiced. There are probably about 200,000 candidates in the United States based on the old labeling for DBS by the FDA. So it's really underpenetrated. And again, I think that's similar to what we see with epilepsy, where even though you're getting seizures, people are very reluctant to go through resective surgery. And I think similar because of the insidious nature of these conditions, you kind of start with one patient, you hit it out of the park, and you develop this kind of rapport with neurologists, and this more and more patients see others with DBS. And so it's almost like a grassroots effect where people seek out this therapy. But it's not at the point where every neurologist who has a patient for 7 years with Parkinson's says, now it's time for surgery. Not experimental, not a treatment of last resort, kind of bang that into people's heads. This is another randomized trial published in the New England Journal of Medicine about 4 years ago, where the average age of patients undergoing surgery here was 51 years old. So it was earlier surgery, and what they showed here was a very dramatic improvement in quality of life in those patients who were randomized to surgery compared to those who were not, such that at the end of this trial, pretty much everybody who had been randomized to medicine wanted to get stimulation. And this trial from Europe was what really drove the change in the FDA labeling in the United States from advanced Parkinson's disease to the following. Dopa-responsive Parkinson's, so that's if it responds to dopamine, levodopa, it's a good indicator it's real Parkinson's as opposed to some other Parkinsonism for at least 4 years. So 4 years of disease, at least 4 months of symptomatic complications, so motor complications like fluctuations and dyskinesias. So 4 years of disease, 4 months of complications, and at that point, the FDA says it's reasonable to consider deep brain stimulation. So I'm going to dive into some of the functional anatomy that's related to what we do. And I think it's nice to simplify this as we're going to look at 3 targets, and there are really 2 planes where we can really see what's going on in relation to these targets and the surrounding anatomy. So one thing that this slide shows is sort of the key plane, the anterior commissure, posterior commissure, AC and PC, right here and right here. And that's the mid-commissural plane. So we kind of have a Cartesian coordinates, x, y, z, in relation to that midpoint between the anterior commissure and posterior commissure. So to have those 2 in the same plane, we've reformatted the MRI, 3-dimensional MRI, and then now we have Cartesian space to talk about where we're going. So at z-4, what I really want to highlight here is sort of the relationship between these different targets, subthalamic nucleus, VIM, GPI. So this is a deep VIM. VIM we usually target at the mid-commissural plane. So -4 means 4 millimeters deep to the mid-commissural plane. And you can see the red nucleus right here. That's the subthalamic nucleus right here. The optic tract is this stripe right here, and you'll see some better pictures of that shortly. But just to get you kind of oriented, where VIM is relatively a posterior target to STN, and GPI is anterolateral. So I'm going to kind of hammer these points in over the next 10 slides or so, because this is really stuff that we don't really soak in too much in residency. So there's the anterior border of the red nucleus, about 3 millimeters lateral to the lateral border of the red nucleus is a nice strategy for picking that spot in the STN. And in this case, using direct targeting, that puts us 11 millimeters lateral, but sort of a classic coordinate is XYZ 12, 3, 4. So 12 out, 3 back, and then 4 down. And you can refine that based upon what you see on the MRI. GPI, here's the optic tract. If you go a little bit further down, you can see, and these are the generic coordinates for GPI, 21, 2, 4, and you can adjust those based upon the patient's anatomy. And then again, VIM posterior to the STN. And I think that's interesting because when people talk about tremor control, neurologists will talk about the posterior subthalamic area as another target that can be considered for tremor control, but the PSA, posterior, is kind of really just a deep VIM. And then going a little bit deeper, so this is at z-4. At z- a little bit further, you can see the optic tracts here come into better view. So it's sort of the dorsal lateral border of the optic tract is the bottom of the GPI. And you can see that here. There's the optic tract along with the posterior cerebral artery. And these kind of shades of gray, the more you look at this, the more they become clear. But this is a coronal view, seeing the bottom of the globus pallidus. Putamen is out here. That's the internal capsule. So you get too close to that, you're going to get capsular side effects, contractions, pulling, and drawing. Close-up view again. This is the optic tract, internal capsule, GPI. And you can see here, this is the Schultenbrand-Warren Atlas coming into view here, that using, this is a proton density MRI, using certain MRI sequences, you can kind of see the anatomy come out just like you would in the in these anatomical drawings. Again, putamen, GPE, GPI, internal capsule, and the optic tract right here. So seeing again, looking at that, as you look at these shades of gray, you can kind of see the same structures that you can see in the anatomical drawings. At z=0, so the mid-commissural plane, again, you can see the relative positioning of GPI, STN, VIM, and look at the relationship of these to the internal capsule. And a lot of board questions people get in the written boards and whatnot talk about what it means if you get a certain side effect with stimulation. And it's instructive to look at this relative to the internal capsule. So GPI is out here, internal capsule, and these two structures. So a little magging up. The globus pallidus I'm usually targeting at the mid-commissural plane, about 4.5 millimeters anterior to the mid-commissural point. There's our internal capsule. And with GPI, it's a really nice target to target directly, meaning instead of using cadaver-based coordinates, refining your coordinates based upon what you see on the MRI. And I based my targeting off of Phil Starr's work on dystonia, kind of identifying the sweet spot associated with best responses to deep brain stimulation, and using that to basically follow that cartoon and picking that sweet spot in the GPI, medial to the GPI-GP border, about 3.5 millimeters off the internal capsule, just outside of this, what we call the accessory lamina, which is a lamina within the GPI. And that's really helpful because the GPI, more than the STN, has variable position relative to midline. This is a patient whose GPI is almost 25 millimeters lateral to midline, whereas this is one where it's 18 millimeters lateral. So using a starting point, at least, of refining your targeting based on MRI helps a lot, instead of trying to fish your way around using recordings to find this discrepancy between 18 millimeters and 25 millimeters. With VIM, you can see right there, we use, you can't really see VIM, so you don't really use direct targeting for VIM, but it's going along the ACPC line. I go about 25% anterior to PC and 10.5 lateral to the wall of the third ventricle. And that kind of matches where the VIM is within the thalamus. And looking from the side, you can see this is a sagittal view. The sensory thalamus is right behind it. So again, a posterior VIM, you'd expect to get sustained paresthesias. And you can see here too that where the STN is relative to this DBS trajectory through the VIM. So again, kind of the snapshot with the internal capsule, it's the relative position of the subthalamic nucleus. This is en route to the actual structure at the midcompensatory plane, the VIM and the GPI. So leaning on that, talk about surgical methods. And basically with DBS, this amounts to hitting a 2 millimeter target through a hole about 14 millimeters wide, 8.5 centimeters deep. So how do you do that accurately and in a way that provides clinical benefit? So I'm going to talk about 4 aspects of this, this goal: the stereotactic devices, microelectrode recording, test stimulation, and then what we use at Barrow, image verification. So the traditional DBS workflow consists of placing a stereotactic frame, taking a patient to CT or MRI, getting a stereotactic image, bringing them back to OR, doing the surgery awake, using sometimes multiple tracks of microelectrode recording to record individual cells, and then putting a lead in, testing it, looking for side effects and clinical benefit. This workflow was basically borrowed from ablative surgery, which was kind of came back into practice in the 1980s for movement disorders. And with ablative surgery, you've got to take extra steps because you're going to actually destroy the brain, and you can't unring that bell. So the stereotactic device, there are many different devices out there, and I think they're all pretty similar. I think ultimately the goal is surgeon comfort. The more you use something, the more accurate it's going to be in your hands. Awake surgery, and then there's the microelectrode recording, so you can map out the electrophysiological structure as opposed to the anatomical structure by hearing these cells firing. And this is an example of recordings. This is the anterior thalamus here, going down. And it really matches what you see on MRI. Then you hit the subthalamic nucleus. The noise picks up. And then you get a very classic sound of the substantia nigra. So with, let's see, is this going to let me do it without the sound? One thing that I find this useful is if I'm trying to guess, without imaging with an awake patient, whether I'm posterior or anterior, if you go through and you don't hear any thalamus on your way to STN, you're probably anterior. If you're a scattered thalamus, that's kind of what I like to see. And if you hear a ton of thalamus, you're probably posterior. And that can inform kind of how you move your lead. And then similarly, the gap between STN and substantia nigra is at the sweet spot, it's the smallest. And the bigger gap you have, the more anterior posterior you might be. So let's get through that. Let's get past that one again. Then test stimulation we use to basically document improvement of symptoms at the time of surgery. So place the lead. Sometimes even just placing the lead, you'll get a microlesion effect immediately where the tremor goes away. But then you see the tremor go away, you test it, have the patient do some movement. Yeah, this is a frameless case. So it turns out that in our experience using MER and test stimulation in awake patients, we find that it usually helps correct for stereotactic error, not errors in targeting. So the information we glean from recordings and testing helps us move toward our MRI-based target. So we use that information to increasingly rely upon where it actually is an imaging space. So it turns out, too, that when we do awake surgery, our movements are more as a result of side effects. We put a lead in and tremor goes away. We don't really say, oh, there's no tremor arrest, let's look for a different spot. So this is a kind of, again, good kind of board issue. The boards always test on this aspect. If you get a STN and you're too far anterior, that's moving you toward the internal capsule, so you're going to get motor side effects. If you're too far lateral, again, you're going to get close to the internal capsule, you see motor side effects. The posterior direction in this area of the subthalamic nucleus and the nucleus is the tingling area, so you get paresthesias. And interestingly, seeing how far anterior STN is to VIM, rarely do I see with STN persistent paresthesias. So no matter how strong the patient feels it seems like they're always transient. I've never really seen a situation where it kept going. It always seems to dissipate. And then medial, there's some third nerve fibers there, so you can get diplopia with that. Similarly with GPI, again, to kind of rehearse and kind of reiterate the surrounding functional anatomy, anterior, basically, these are air balls. You don't get effect. Same thing with a laterally displaced electrode, no effect, so you're going to get an air ball. Posterior, you're going toward the internal capsule. We get motor, and medial, same thing. So in so much of this, I feel like sensory and motor, those side effects are really what we're using to kind of check out who our neighbors are, to verify that we're kind of tucked into the right spot. In fact, with STN, increasingly we're trying to kind of move it closer and closer to the STN, to the internal capsule, without kind of going past that point where we have unacceptably low thresholds for capsular side effects. Same thing with VIM. You can hit capsule if you go anterior. Lateral, obviously, is toward the internal capsule there. Posterior, like we saw in that other picture, that's where you have the sensory thalamus. So posterior, you get paresthesias. And then medial, you get basically no effect. Sometimes they say, medial you can get dysarthria, and lateral you get dysarthria. With bilateral VIM, I've heard a neurologist say if you get dysarthria, it means it's in the right place. So, and then deep, if you go too deep with GPI, you're going to hit the optic tracts and you're going to get phosphenes. If you go too deep with an STN lead, with the substantia nigra, you can have people like crying in the operating room or something. You get mood changes. So, like I said, increasingly we see that our testing kind of helps refine for stereotactic error, but not for targeting error. So there's various reasons why it's been done awake. A lot of it is informed by the ablative era of functional neurosurgery. Also, there can be brain shift, and if you're starting from atlas-based coordinates, you need to refine the coordinates to the patient's own anatomy. What we've been using is, as a result of the increasing availability of intraoperative imaging, we use a CT scanner in surgery, both for registration as well as for lead verification, and use that coupled with direct targeting that we use with MRI to perform this operation. And there's a lot of strategies for targeting. On YouTube, I've got my planning videos that kind of go point by point on the stealth station, how I go about planning a VIM, GPI, and STN electrode. But this is a video showing sort of the workflow that we use. The nice thing, I think, one advantage among many, I think, is that once we have the patient in the frame, we don't move the patient at all, so there's no risk for really micromotion of the frame, which could set off your stereotactic accuracy. And you can see the anesthesiologist and that team kind of going to town lower on the patient as we're getting the patient in the frame and getting our scan. We merge that scan to our MRI, and then we proceed with lead placement. And it's basically sharpshooting, right? The goal here is just to hit the target that the surgeon picked. The assumption, I emphasize always, is that the surgeon picked the right target. If the surgeon picks the wrong target, doesn't matter how close the surgeon gets, you're not going to get good results. So patient will get out of surgery fine, but the therapy won't be successful. So good MRI-based targeting is key. So we use the intraoperative CT, verify our accuracy, and then the way we do it down in Phoenix is patients proceed from here and they get their generator done in the same sitting. So we'll do one of these in the morning, a bilateral with the IPG, and then we do another one in the afternoon. These are the pictures that we look at. This tells us how far off we are over in this corner. 0.7 millimeter error. You can see the 4 contacts of the Medtronic lead that span about half a centimeter. And there's our error right here, 0.5 millimeters, and we can see the electrode sitting in that sweet spot. And so we combine that direct targeting with the intraoperative imaging to perform this under general anesthesia. We're not using recordings, we're not doing test stimulation, and we basically are using anatomical accuracy as our surgical endpoint. Again, the assumption being that the surgeon picks the right target. And we transitioned about 1.5 years ago to only doing a sleep surgery. So we've done about over 1,100 leads now in over 600 patients. And to date, because we're not doing awake anymore, we're 72% of our cases have been done asleep since 2011. In accuracy, 0.9 millimeters is our mean error. Outcomes, we test our patients at 6 months for Parkinson's, and we test them at 3 months for tremor, and we've published on this. Basically looking to see what percentage we close that gap between on and off, which is really what patients suffer from when they are looking at DBS as a solution. So we've seen that we kind of meet all the metrics expected for closing that gap between on and off medications when on stimulation. And same thing with tremor. We see similar results between awake and asleep functionally. So, the question that we've assessed over the course of our use of this, it's been 5 years now that we've been doing asleep, and 1.5 years that we basically, in order to offer a consistent package to our patients, stopped offering awake. Does our ability to verify that we hit our target intraoperatively reduce our need for MER and test stimulation? And I think that it also decreases the likelihood you're going to find yourself in a position where you have to revise a lead. Just like using navigation to place shunts, we don't really, at Barrow, we never do freehand shunts anymore. If you put a freehand shunt and you miss the ventricle, first thing they ask you is, did you use navigation and why not? And increasingly too, we're seeing more and more placement of spinal instrumentation using navigation and using the same devices to verify appropriate positioning of the hardware. And I think we're seeing that more and more with DBS, that you can really kind of leave your signature at the end of surgery, documenting that you hit the target that you intended to hit. So DBS is currently underutilized for tremor and Parkinson's. Medicare has actually recognized that this is an underutilized treatment. There are various methods to confirm the DBS target has been hit. It's a nice crutch to see that the tremor stops, but we're finding that just making sure that you hit that target that's been kind of defined over decades of doing this operation appears to suffice. And these novel strategies for surgery may render this therapy, brain surgery for quality of life, more accessible and more palatable to patients who stand to benefit from it. So thank you for your attention.